Welcome back, everyone, to part 53 of our IPDRG Masterclass. It is so great to have you here today. In our last lesson, we tackled MDC 18 and 19, infectious diseases and mental disorders. Well, today, we're pushing even further into the complex world of major diagnostic categories, specifically MDC 20 and MDC 21. We're going to be looking at substance use, injuries, poisonings, toxic effects, and the absolutely crucial clinical documentation rules that tie them all together. But real quick before we jump into the weeds here, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. All right, here's our roadmap for today's explainer. First, a quick intro and recap. 2, substance abuse and detoxification. 3, poisonings versus adverse effects. 4, CDI specificity. And 5, our summary and teaser. Let's get right to it. Okay, section 1, intro and recap. Let's briefly reset our DRG foundation before we get into the new stuff. Remember how this whole puzzle fits together? The inpatient prospective payment system relies on a few key inputs to figure out hospital reimbursement. You've got your principal diagnosis. That's the main reason for the admission after study. Then you have your secondary diagnoses, which act as our comorbidities and complications, or CCs and MCCs. Toss in the procedures and patient demographics, and you've got the whole picture. Honestly, a single missing demographic detail here can literally change a hospital's entire bottom line. So the MSDRG grouper basically acts as our logic engine. It takes all of those inputs, your ICD-10-CM diagnoses and your ICD-10-PCS procedure codes, and calculates the exact DRG and relative weight. Your principal diagnosis sets your major diagnostic category, and your secondary diagnoses determine your severity tier. Pretty straightforward, right? Moving right along to Section 2, Substance Abuse and Detoxification Coding. This is where we hit MDC 20 territory. You know, within inpatient coding, the word detoxification isn't just some casual catch-all term. It actually has a very rigid definition. It's the active process of removing toxic substances to help a patient stabilize physically and psychologically until their body is completely free of drugs or alcohol. And what's really fascinating here is that in ICD-10 PCS, detoxification services gets its very own specific root operation type. Let's look at the methodical process of building one of these codes. In ICD-10 PCS, we always start in Section H for substance abuse treatment. The body system is Z, which just means none. The real magic happens in position 3, the root type. Like I just mentioned, a 2 is for detoxification, while a 3 is used for individual counseling. Finally, position 4 is our type qualifier, specifying the exact method used. It's like building blocks. The crucial point for us as coders is that every single character matters immensely. Take a look at this example code, HZ34ZZZ. We start with H for substance abuse treatment, Z for none, 3 for individual counseling, and 4 for the interpersonal qualifier. The last 3 characters are just Zs for none. By capturing this with maximum specificity, we're painting a perfectly accurate picture of the true clinical resources consumed during that patient's stay. All right, Section 3, poisonings, adverse effects, and underdosing. This falls under MDC 21, and we need to make these concepts crystal clear. This is a massive learning objective, so listen up. You have to memorize this distinction. A poisoning is when a condition is caused by a substance being used incorrectly. This means an overdose, taking the wrong dose, using a non-prescribed drug, using the improper route of administration, or using any illegal drugs. On the flip side, an adverse effect is a condition caused by a drug when it was used entirely correctly and exactly as prescribed. It's all about intent and proper usage. Now, do not confuse those first two with underdosing. Underdosing is a totally separate, highly specific thing. It happens when a patient actively reduces their medications, basically taking less than what they were prescribed. If a patient comes into the hospital for a severe condition simply because they stopped taking their heart medication, that's a unique coding scenario requiring really precise clinical documentation. Which brings us right into Section 4, CDI and clinical documentation specificity. This right here is exactly why clinical documentation improvement, or CDI, matters so much in the IPDRG environment. If a provider just scribbles drug reaction in the chart, well, you as a coder cannot assign the proper code. You're stuck. And that directly leads to incorrect DRG assignment, major underpayments, payer denials, and totally distorted quality metrics. As an expert coder, you are the final line of defense.
You have to initiate a formal CDI query whenever the physician's documentation falls into one of these 5 buckets: incomplete, conflicting, ambiguous, inconsistent, or just completely unsupported by the clinical indicators in the chart. For example, if the lab shows severe toxicity but the doctor only wrote overdose, you have to query for the intent. Was it accidental, intentional self-harm, and assault? We need to know.
But wait, there are incredibly strict compliance rules here. You cannot use a leading query. That is strictly forbidden. A leading query suggests the answer, like asking, hey, can we code this as acute blood loss anemia? You're basically feeding them the answer. Instead, you must use a compliant, non-leading query. You provide the clinical facts and ask for clarification, like, can you clarify if the anemia is acute, chronic, or due to another cause? You have to allow the provider to independently make that diagnosis. Let's move over to another critical piece of documentation that drives our DRG, the present on admission or POA indicator. This is mandatory for every single inpatient diagnosis. POA logs basically tell the timeline of the patient's condition. Y means yes, it was present when they walked in the door. N means no, it developed during the stay. And honestly, getting this single little letter wrong has absolutely massive financial implications for the hospital. And here's why that is. Under the Deficit Reduction Act, if a secondary diagnosis is flagged with an N, meaning it wasn't there on admission, making it a hospital-acquired condition, CMS often will not allow it to increase the MSDRG payment. So think about that. If a patient comes in for a routine procedure and accidentally suffers a medication poisoning while in the hospital, that severe complication won't count as a CC or MCC to boost reimbursement. Accuracy here is vital. Okay, Section 5, Summary and Teaser. Let's bring all these concepts home. The main takeaways from today's lesson are pretty clear. First, specificity is the absolute engine of DRG accuracy. Every single character in those PCS codes matters. Second, you have to clearly distinguish between poisonings, adverse effects, and underdosing based purely on intent and correct usage. And third, when the documentation is vague, it's on you to use compliant, non-leading CDI queries to capture the true severity and the correct POA status. Next time, in Part 54, we're going to dive into further DRG classifications, including Burns MDC 22, and we'll look closely at how Z codes representing factors influencing health status play a crucial role in our coding ecosystem. It's going to be a great one. Just a quick reminder before we go, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. I want to leave you with this final thought to challenge your daily practice. Ask yourself, are your CDI queries uncovering the true severity of your patient's condition, or is vague documentation leaving your hospital's revenue and accurate patient health records sitting on the table? Keep that in mind as you code your next chart. Thanks for joining me, and I'll see you in the next lesson.